the American people. Thank you.
I'll move quickly. I want to thank the IOM for inviting me to speak today, and also thank the committee for their great work on which not only today's discussion but a lot of other discussions over the past several months have been based. I also want to thank Peggy and Rebecca for their personal and really compelling comments. I'm going to lift up more to the 30,000-foot level in my comments, but with the backdrop, I think it's useful to keep those personal comments in mind because that's what really matters in all of this. The topic of today's panel is integrating financing for medical and social services. The bottom line is that people at the end of life have always had a range of interconnected needs: medical, social, spiritual, psychological. The only reason they're distinguished in policy discussion reflects the fragmented nature of the Medicare program and reflects the lack of supportive services outside of the Medicare program, Medicaid being the primary coverage that people have, which is fairly inadequate. The IOM committee highlighted this dilemma and concluded that comprehensive reforms, not piecemeal reforms, were needed to substantially improve end-of-life care for individuals, to better align the care that they receive with their preferences, to allow them to stay at home if that's what they preferred. And they really highlighted the need for a better mix of medical and social services, and in particular called out several social services that you can read about in their report. And I should also note that you can read the chapter on which my comments today are based, that Hayden Huskamp and I wrote, to get a much fuller discussion of some of the issues that I'll only raise here. The committee also recognized the need to be politically and fiscally realistic. They noted that any expansion of social services would ideally be paid for in terms of reduced hospitalizations, reduced ED use, reduced nursing home admissions. And so there was some expectation that they weren't just adding services, they were creating value in doing so. And so that was the context for which they made these recommendations. So with that as a backdrop, today I'm going to discuss mostly the Medicare hospice benefit, how it's changed over the past 30 years or so, and how it could change going forward to better interface with the healthcare delivery system and also healthcare delivery reform. Hospice is the primary mechanism by which Medicare pays for end-of-life care. 1 in 2 Medicare decedents now uses hospice before they die. As many have talked about today, hospice has a comprehensive team-based approach. It's interdisciplinary, it's focused, and it's patient-centered and family-centered in its approach. It's really all that you'd want it to be. But it's having a hard time meeting its goals given how much it's changed over the past 30 years. The benefit has changed from being one primarily for individuals with cancer living at home to being one primarily for individuals with non-cancer diagnoses living in a diverse array of settings, including nursing homes and assisted living facilities. This is very different than when hospice first started. These are creating substantial populations, not only in terms of these different populations, but also in whether you think about how hospice is provided across settings, and also the provider mix of hospice has changed markedly, from community-based nonprofits to many more nonprofits and many national corporations as well. Now, in terms of how policymakers and some researchers have responded to this, there's typically, over the past decade or so, been a fairly narrow focus on appropriate use. And in fact, there's been a pretty narrow focus on long hospice stays. And to a comment that was made earlier by Dr. Waugh, the hammer is payment reform, and everything looks like a nail, in terms of what needs to be done about the hospice program. But payment reform alone won't address fundamental challenges about how hospice connects with the rest of the healthcare delivery system and the ways in which that same system is changing. They just won't. And it also won't address necessarily the limitations that several people spoke about this morning of many people accessing hospice only very late in the process of dying, a day, 2 days before they die. And payment reform alone won't change those dynamics. We really need to think beyond that. There are a lot of opportunities, as we lay out in the chapter that we wrote for the committee, to improve end-of-life care in the context of the current emphasis on value and integrated financing and delivery. I'm going to talk about a few of those and talk about some missed opportunities and how we could potentially move forward. First, Medicare Advantage. It's come up several times in discussion today. Medicare Advantage plans, because of the way they're paid on a per person as opposed to per service basis, are incentivized to coordinate care, to minimize fragmentation, and to reduce overutilization of unnecessary care at the end of life. One caveat that's been discussed already is that hospice is carved out of the Medicare Advantage program. Under current statute, if an individual who's in MA elects hospice, their hospice is handled fee-for-service, their non-terminal care is handled fee-for-service Medicare. The only benefits that stay within Medicare Advantage are the supplemental benefits that the Medicare Advantage plans provide: vision, dental, hearing, things of that sort. And so the Medicare Advantage plans cede financial and clinical responsibility for those individuals once they elect hospice. Now, there are trade-offs. Plans have the strong incentive to encourage hospice use. If they have an individual who needs, potentially hospice care, they have a financial incentive to do so, and it also might be in the best interest of that individual as well. But ending the carve-out, ending the hospice carve-out, something that MedPAC and some others have recommended, it could push plans to coordinate care for all individuals with advanced illness at the end of life, whether or not they elect hospice or not. It could also take away some of the barriers to hospice enrollment that have to do with eligibility policy, the 6-month standard, the decision to forego curative care. Conceivably, if MA plans had flexibility to integrate hospice and palliative care into their benefits for enrollees, they could alter those scenarios if they chose to do so. And we heard several times this morning about the success that Aetna has had on the commercial side, leading one to at least wonder, can we discuss this? Can we have a further policy discussion about how hospice might be carved in to the Medicare Advantage benefit? And to be sure, there are some safeguards that would have to be in place that I'll come back to in just a minute. So in terms of other palliative care and social services in Medicare Advantage, apart from the hospice side of things, anecdotal evidence suggests that palliative care services are already being integrated into Medicare Advantage, and some things work in favor of that early integration. First, as people have talked about today, studies have shown that early integration in palliative care for certain populations can be cost-effective and it can improve quality of care. Second, in terms of thinking about it from a financial risk standpoint of the MA plans and offering a palliative care benefit, there are certain barriers to its use, and this will be relevant in just a second when I talk about social services. There are certain barriers to its use that limit the demand for palliative services. So from offering it as an MA plan, those two things, the cost effectiveness and the somewhat limited demand potential for it, make it easier for them to offer those types of services. I think harder things, it's harder to say that for some of the supportive services that are highlighted in the IOM report, whether it's transportation, whether it's meals and nutrition programs, whether it's home modification, things of that sort. Studies have not consistently shown the same types of cost savings for those types of services. And so MA plans might hesitate to offer those types of services, or other types of organizations might hesitate to offer those types of services. And there's also the challenge of those services can be fairly appealing to individuals. In long-term care, the field that I started off in, there's this notion of the woodwork effect, that if you offer certain services, people will come out to get them in larger numbers than you might anticipate. Therefore, targeting can be quite important. So I want to talk about beyond MA, and I'm at 10 seconds, but I'm going to go a little bit over. I promise to keep it 2 minutes. So other coordinated care efforts. First, 2 efforts, the bundling demonstration, the BPCI, and the duals financial alignment demonstration. Both of those demonstrations carve out hospice. An individual elects hospice, they're out, although some financial alignment, it's slightly different. But opportunities are being lost by carving out hospice, by restricting people who enroll in hospice from those types of coordinated care demonstrations from participating. Second, end-of-life care in the context of ACOs, which has the potential to affect a far larger number of Medicare beneficiaries. I think it's important to talk about this. ACOs overall have similar incentives to MA plans to minimize low-benefit, high-intensity procedures at the end of life. Unlike MA, hospice is not carved out of the ACO demonstration. So it's not carved out. But the challenge has to do, not to get into the weeds too much, has to do with this notion of attribution. If an individual elects hospice and receives the bulk of their primary care through a hospice provider, they might be assigned away from the ACO. And so there can be kind of funny incentives, even though it's not carved out, there can be funny incentives in terms of individuals accessing hospice and palliative care services at the end of life. Finally, there are some important safeguards that need to be thought of in terms of considering integrating hospice and palliative care services into a broader benefit package. And we need to keep an eye on the potential challenges as we move forward in terms of policy discussions in this area. Safeguards are needed to measure and monitor end-of-life care quality, the adequacy of provider networks, and also beneficiary freedom of choice. Those don't exist on the MA side. HEDIS measures don't include end-of-life measures. They don't exist for the ACOs either. And so we're going to have these quality measures in place if we do want to move forward in this area. So I'm going to end with my bottom line above. People at the end of life have always had a range of interconnected medical, supportive, palliative, and spiritual needs. Now, as Medicare moves toward a greater emphasis on integration and on value, there are opportunities to reshape individuals' care and align it more closely with what they want at the end of life. Hospice is a central part of this equation, but it needs to be viewed as less of an escape from traditional medicine and traditional care at the end of life, and more as a central component to high-quality care. Thanks.